So we have done the pre-test for this MCQ, and the highest score was 7/10. So now we are going to go through the discussion of the questions so that you see the questions again and the respective discussion. So the first question says, shock. The following statements are true except cardiac tamponade can be a cause of shock. B, typhoid enteritis can be a cause. Acute renal failure is a sequelae. Oxygen is never required in the treatment. E, baroreceptors are involved in the production of cold, clammy skin. Now, obviously, the answer here is D. Oxygen is never required in the treatment. Oxygen deprivation or failure of oxygen to reach the tissue, which is cellular hypoxia. Cellular hypoxia is the hallmark of shock. So, except oxygen is never required in the treatment. That is not correct. Shock is a clinico-pathologic state characterized by poor tissue perfusion and its attendant metabolic sequelae. Major etiological causes are hypovolemia, which is the most common cause, of course, and due to plasma volume depletion. So hypovolemic shock is the commonest type of shock. There are two types of hypovolemic shock. It could be hemorrhagic from blood loss or non-hemorrhagic from plasma loss. And up to 1 liter of blood is lost for a patient to develop shock. While in a non-hemorrhagic shock, up to about 3,600 mils of plasma or extracellular fluid is lost for a patient to develop shock. So the commonest type of shock is hypovolemic shock, and there are two types of shock, hypovolemic shock, hemorrhagic and non-hemorrhagic. So others are cardiogenic, neurogenic, septic, and anaphylactic shock. Poor tissue perfusion leads to hypoxia, and at the tissue level, anaerobic glycolysis. Thus, oxygen is central to management of shock, especially septic and anaphylactic shock. Cardiac tamponade, which is the first option, can cause cardiogenic shock. Typhoid enteritis can cause both hypovolemic from diarrhea and septic shock. Baroreceptors pick up drops in effective plasma volume as well as pressure and signal a cascade of reflex pathway leading to shunting of blood from skin, renal, and splenic beds to supply the heart, lungs, and brain. So baroreceptors, they are responsible for peripheral diversion of blood to supply the main vital organs, which is the heart and the brain, to maintain these vital organs. These processes are responsible for cold, clammy extremities and decreased urine output. In severe cases, the diminished renal blood flow can cause prerenal failure and acute tubular necrosis. So that is regarding question 1. If you have any question on this, you can ask before we proceed. Any question? Okay, no question. The next question says, by which route of administration will a drug have a definitive predictable response in a shock patient? In a shock patient, which route is more predictable in a patient with shock? A, oral. B, rectal. C, intramuscular. D, subcutaneous. And E, intravenous. Which one is more predictable? Of course, in a patient in shock, the more predictable route of administration is intravenous because of the reason we mentioned earlier. When there is peripheral and splanchnic diversion of blood, okay, that means in the intestine, oral absorption, if you take drug via the oral route, if it gets to the intestine, absorption is impaired because there's diversion of blood from the splanchnic circulation. Intramuscular, the same. There's diversion from peripheral circulation and subcutaneous. So intravenous is the more predictable. Now, in shock, the interplay of homeostatic mechanisms ensures the shunting of blood from the skin and the gastrointestinal tract to the heart and the brain. Thus, absorption of drug from the skin and the gastrointestinal tract will be delayed and unpredictable. Hence, the bioavailability of drug is best achieved via by the intravenous route. So any question here? If it is clear, we proceed. Okay, the next question. In first aid, the most sensible line of action for a multiply injured hypovolemic shocked patient is A, intravenous steroid hydrocortisone. B, intravenous adrenaline plus reduction of fractures. C, random blood sugar for diabetic coma. D, CT scan of the skull for head injury. Now, the first line, the first aid is to expand the effective circulating volume. Of all these options that are provided, intravenous normal saline 1 liter is given fast to expand the intravascular volume. Now, you should know in hypovolemia, the problem is plasma volume depletion. And the most sensible thing will be an attempt to restore this. And the best fit option will be a plasma expander, which could either be a crystalloid like normal saline, Ringer's lactate, Hartmann solution, or a colloid like isoplasma, blood, dextrans, hemacil. But you should know that in a shock patient, the first fluid that is preferred is crystalloids because they diffuse into the interstitial space and deliver more oxygen. They clear microthrombi. When you give crystalloid, 2/3 tend to diffuse into the interstitial space, carrying oxygen to this space, while you have 1/3 remaining in the intravascular compartment. Okay, so the first fluid you give preferably are crystalloids. They are readily available compared to colloids. Now, intravenous steroids are useful in anaphylaxis, immune reaction modulation, and in Addisonian crisis. Now, even in other forms of shock, you should know the first line of treatment is intravenous fluid administration. Even if it is an anaphylactic shock, you don't start by administering all these agents. The first line of treatment of any form of shock is IV fluids. Intravenous adrenaline is useful in acute resuscitation for cardiac arrest, where its chronotropic and inotropic effects are desirable. Not all fractures are associated with shock. Common shock-associated fractures are pelvic fracture with retroperitoneal hemorrhage and femoral fracture with vascular injury, because these fractures that are mentioned, for example, the femoral fracture can accumulate up to 2 liters of blood within the thigh. Okay, now if 1 liter of blood is what is lost for a patient to develop shock, and each femoral fracture can actually accumulate up to 2 liters. Just imagine a patient with bilateral femoral fracture. That patient will exsanguinate. Diabetic coma is a metabolic state that is not usually associated with hypovolemic shock. Okay, it's not usually associated with that. Neither is CT scan the first aid protocol. So any patient in shock, the most preferred option here is to give IV fluids. Okay, 4 hours after sustaining open femoral fracture plus splenic laceration, an adult male with a BP, blood pressure of 80/60 millimeters of mercury plus pulse rate of 125 beats per minute and cold, clammy skin is suffering from A, early septic shock, B, hypovolemic shock, C, cardiogenic shock, D, late septic shock, and E, neurogenic shock. As we mentioned, the types of shock include hypovolemic shock, which is the commonest type, which could be hemorrhagic or non-hemorrhagic. Okay, there is septic shock, there is anaphylactic shock, there is neurogenic shock, and there is cardiogenic shock. Now, for septic, neurogenic, and anaphylactic shock, they are categorized as distributive shock because they are characterized by peripheral vasodilatation and pooling of blood in capacitance vessels. Then the venous return is impaired, cardiac output is impaired, and in such case, they have warm extremities rather than cold, clammy extremities. So septic shock is a distributive shock, okay? And neurogenic shock and anaphylactic. So now if you look at this question, these patients had femoral fracture, which I told you can accumulate. This is even open, so you will be losing blood to the exterior, and splenic laceration. He has internal bleeding, so he has both external and internal hemorrhage. And you see the blood pressure is 80/60. Anything less than 90/60, patient is in shock, and a pulse rate of greater than 120 beats per minute. So the answer here is hypovolemic shock because patient is losing blood, both internal and external bleeding. Now, open femoral fracture and splenic injury are associated with substantial bleeding, which may result in hemorrhagic shock. A form of hypovolemic shock. Septic shock within 2 hours of injury is not likely within 2 hours. So this is a very important statement, except the patient had, for example, retral catheterization, okay, without adhering to aseptic protocol. And this was not stated in the question. Cardiogenic shock and neurogenic shock are not true, as no mention was made of cardiac or spine injury, respectively. Those are common causes of this form of shock, that were mentioned. Hypovolemic shock is characterized by body fluid loss, including blood, with associated fall in blood pressure and pulse volume, as well as a rising pulse rates. The next question, clinical features of patients with multiple injuries and hypovolemic shock may include the following, except we are looking for the negative option here. Oliguria and anuria. Of course, they will have prerenal, acute renal failure. There will be peripheral and diversion of blood, okay, in the second stage of shock. Even the perfusion to the kidneys are reduced. Hypotension and tachycardia, okay? Hypotension and tachycardia, that is correct. Pallor and restlessness, altered mental states. So all these are features of shock. So your most appropriate will be none of the above. So hypovolemic shock is associated with decreased plasma volume, which is in this case is due to blood loss. Okay. Clinically, the patient presents with low volume pulse, tachycardia, sweating, cold, clammy extremities, pallor, tachypnea, and altered sensorium. Okay. Bradycardia is not a feature of hypovolemia, except, this is very important, except as a terminal event in cardiopulmonary failure, except as a terminal event in cardiopulmonary failure. Number 6, clinical features of a patient with neurogenic shock include which of the following? A, hypertension and tachycardia. B, hypotension and tachycardia. C, hypotension and bradycardia. D, hypertension and bradycardia. And E, hypertension with normal pulse rate. Now, neurogenic shock is a form of distributive shock that is characterized by widespread inhibition of sympathetic outflow. When there is inhibition of sympathetic outflow, there is peripheral vasodilatation and pooling of blood in the capacitance vessel. So the venous return to the heart will decrease, leading to reduction in the cardiac output and hypotension. And they have associated bradycardia because of the inhibition of sympathetic outflow. So your more appropriate answer here is C. Okay. Neurogenic shock is a type of distributive shock consisting of the hemodynamic triad of, these are the triads now: hypotension, bradycardia, and peripheral vasodilatation results from loss of sympathetic stimulation of blood vessels and unopposed vagal activity. So these are the two important mechanisms. sympathetic outflow inhibition, and unopposed vagal activity. Hypovolemic shock presents with the following features except A, tachycardia. We are looking for an except. B, mental dullness. C, oliguria. D, collapsed peripheral veins. E, hypertension. Okay? Hypovolemia does not present with hypertension. All these are features of hypovolemic shock. Hypovolemic shock is usually associated with hypotension due to reduced cardiac output. It may result in oliguria due to reduced renal perfusion, mental obtundation due to reduced blood flow to the brain, and collapsed peripheral vein. Hypertension is not a feature seen in shock. Number 8. A 40-year-old male with open fracture of the femur associated with splenic laceration with a blood pressure of 75/65 millimeters of mercury and pulse rate of 130 beats per minute and a cold, clammy skin is suffering from, we said, hypovolemic shock. You can see the BP is low, the pulse rate is more than 120, and cold, clammy. Cold, clammy, this is distributive shock. They have warm extremity. This is distributive shock. They have warm extremity. This is distributive shock. They have warm extremity. Then this hypovolemia, you can see you have, what do you call it? Decreased blood pressure as well as tachycardia. And of course, the cause is open fracture of femur and splenic laceration. So there's hemorrhagic. It's a hemorrhagic form. You can see it's not impairment of any heart contraction. So our answer here is D. Number 9. A 32-year-old male transporter complained of left shoulder tip pain with abrasion on the left thoracoabdominal region after a vehicular road traffic accident. His blood pressure is 75/45 with pulse rate of 130 beats per minute. The most likely diagnosis is A, left femoral fracture, B, left hemothorax, C, left renal injury, D, splenic injury shock, D, cardiac tamponade. Now, if you look at this, left shoulder tip pain is the referred pain due to accumulation of blood under the diaphragm. Now, abrasion in the left thoracoabdominal region signifies that there is an internal injury, most likely the spleen. That is the location of the spleen. So when the spleen is ruptured, patient suffers internal bleeding, and you can see they already have what is called Kett sign, a referred pain to the tip of the left shoulder due to left subdiaphragmatic hematoma, and this patient is in shock. So our most appropriate answer here will be D. Okay. Splenic injury may be associated with left shoulder tip pain due to diaphragmatic irritation from a splenic hematoma, which is felt as a referred pain at the tip of the shoulder. That is called Kett signs, is demonstrable by a reverse Trendelenburg. Trendelenburg is head down position. Reverse Trendelenburg is head up position. So if you do a reverse Trendelenburg, they'll have the pain in the tip of the left shoulder. Now, tachycardia and hypotension are features of shock as a result of blood loss from splenic injury. Okay, telltale signs of splenic injury include left flank abrasion. Sometimes you might have even fracture of the left lower ribs because the spleen runs along the 9th to 11th ribs on the axis of the 10th rib. So if you have associated fracture of these lower ribs of the left side, it's also a telltale sign of splenic injury. The type of shock that may result from burns include A, septic shock, B, neurogenic shock, C, hypovolemic shock, D, all of the above, and E, none of the above. Now, shock is a clinical condition. Burns is a clinical condition that can cause all forms of shock. Burn injury is peculiar in that it is associated with coagulative necrosis of tissue. For cutaneous burns, there is loss of the natural hemostatic mechanism from skin temperature and fluid regulation. This leads to increased loss of fluids and electrolyte through the burnt skin, increased insensible water loss. This loss must be significant enough depending on percentage burn and degree of burn injury to cause hypovolemia. Similarly, the burnt skin function acts as an impervious layer for entry of microbes, a role augmented by secretion of immunoglobulins by skin. Thus, burn injury patients are prone to sepsis, which may be sufficient to cause septic shock. Burn injury, especially the superficial type, may be associated with severe pain, which in itself can cause neurogenic shock. Thus, treatment of burn patients will include adequate fluid and electrolyte management, prevention and treatment of any sepsis, as well as pain management. So these are the first 10 MCQs we are going to do today. We are not going to do much. Today we are having a shorter session so that you understand the pattern of the MCQ discussion. Now, the pattern of the MCQ discussion, as mentioned, we are going to start with a pre-test. And if you come late, as you can see today, somebody is getting 0/10, somebody is getting 3/10, Karimatu is getting 1/10. They came late. So if you come early, you answer all the questions, then we'll now mark it. When we mark, then we now read through and do the discussion. So I'll encourage all of you to join early and participate in the pre-test. We are going to answer, God willing, all the topics in surgery, in all the specialties, from principles, general surgery, urology, orthopedics, and all other subspecialties. So the more you participate, the better for you. So secondly, I'm going to share the lecture, the previous lecture on shock, so that you can go through the lecture before the main lecture comes. And in fact, it's going to prepare you more so that when you are reading, you know the areas that are very important. So we are going to stop here. But before we do that, if you have any questions, you can ask so that I will answer them. We end the meeting. Thank you very much. Any question? Okay, it appears that you are all sleeping. So let me just end the meeting.